Alright, welcome back everybody. Today we have Chapter 9, which is a continuation of the circulatory system. And today we're going to take a close look at the heart. Obviously the heart is a pumping mechanism that is able to circulate blood throughout the body and deliver oxygen and other nutrients to the cells, and also to help remove waste products from those same cells. Now the heart pumps blood through two circuits. Okay, the first circuit is the pulmonary circuit, which is blood making its way through the lungs to drop off CO2 and to pick up oxygen. The right side of the heart is responsible for pumping blood into the pulmonary circuit. And then we also have the systemic circuit, which is responsible for pumping blood to all the other cells of the body. Okay, and the left side of the heart is responsible for basically delivering blood with a high oxygen level to all the tissues of the body, and then eventually the systemic circuit will return blood to the right side of the heart here. So here's the right side of the heart. We have deoxygenated blood returning from systemic circuit. Right side of the heart is going to pump it through the pulmonary circuit. CO2 is dropped off, O2 is picked up, and then once blood becomes oxygenated again, it will return to the left side of the heart, and then the left side heart will pump it back into systemic circuit to all the tissues of the body. Now when you look at the location, the heart is found in the mediastinum. Okay, the base of the heart is found toward the top. Apex is found toward the bottom here. The size of a heart is about the same size as your fist. Okay, and it slightly favors the left side of the thoracic cavity in most people. However, there's a condition called dextrocardia, where the heart happens to favor the right side of the thoracic cavity, but for most people it's going to be on the left side here. Now the heart is enclosed, okay, by a tough fibrous sac called the pericardium, or the pericardial sac. The pericardial sac has two layers. When you look at the two layers, the pericardial sac includes the parietal pericardium, visceral pericardium. You may remember those terms from Chapter 1. Remember, a parietal layer is lining the cavity, visceral layer is on the surface of the organ. So superficially, we have the parietal pericardium. It's an A. Okay, and the parietal pericardium itself has kind of two layers: a superficial fibrous layer and a thin serous layer, deep to that. And then we also have the visceral pericardium. Now the visceral pericardium is on the surface of the heart itself, and it's actually considered to be the outer surface of the heart. Now there's another name we use for the visceral pericardium, and that is the epicardium. Okay, and in between these two layers, between the parietal pericardium and visceral pericardium, there is a potential space called the pericardial cavity, which is filled with serous fluid that functions as a lubricant. And these membranes can become inflamed because somebody has some type of infection within these membranes. It can lead to pericarditis, which can be quite painful for that individual every time the heart beats. So just a good view of these membranes. Here's the pericardial sac. This is the fibrous layer I was talking about earlier. Deep to that, you have the serous layer. Serous layer kind of folds back on itself. When it folds back on itself, it will then start to basically be found on the surface of the heart, and this membrane here on the surface of the heart, that's your visceral pericardium. And once again, another name for the visceral pericardium is the epicardium. And you can see the pericardial cavity in between the two. Now if you look at the wall of the heart itself, it has three layers. It has the outer layer right here. This is the epicardium, same thing we saw up here, once again also called the visceral pericardium. We have the endocardium, which lines the internal chambers of the heart. And in between these two layers, we have the thickest layer of the heart, and this is the myocardium. And this is where we find all the muscle that's needed to pump blood through the pulmonary circuit or through the systemic circuit. Okay, so make sure you're aware of these different layers of the pericardial sac and different layers of the heart itself. Now the heart does have four chambers that it uses, okay, to pump blood through the pulmonary and systemic circuits. You have two atria, which are found toward the top, and you have two ventricles. which are found on the bottom. Okay, so if we take a close look here, we have the right atrium, we have the left atrium. I do want to remind you it's the patient's right and left, okay, it's not your right and left. Now the two atria are separated by intra-atrial septum. Okay, and the walls of the atrium, okay, have these elevations that are referred to as pectinate muscles, okay, that are found in the atria. You look at the two ventricles, okay, we have the right ventricle, we have the left ventricle. They're separated by a septum as well. You have the interventricular septum, okay, and the walls of the ventricles are elevated with muscles also, and these are referred to as trabeculae carneae, okay, and those are found in the ventricles only here. Now, if you go back to the atria, okay, the atria are covered with two ear-like flaps, okay, and the two ear-like flaps that cover the atria, those are referred to as auricles. Okay, so you have what's called the right auricle, covering the right atrium, and we have the left auricle, okay, that's covering the left atrium. Okay, so we see the term auricle is just ear-like flaps associated with the atria here. Now, continuing with the external anatomy, okay, there are grooves externally that separate the atria from the ventricles. Now, a groove that separates the atria from the ventricles is called a coronary sulcus or atrioventricular sulcus. So right here, between these two lines, okay, this is the coronary sulcus. Okay. Within that sulcus, you will find blood vessels or coronary blood vessels. You also have a sulcus that separates the ventricles. We call this the anterior interventricular sulcus on the anterior side. Here's the anterior interventricular sulcus. Once again, you'll find coronary blood vessels within that as well. And just turn the heart around. This is a posterior view of the heart. Here's the continuation of the coronary sulcus. Okay, and on the back we have the posterior interventricular sulcus, which is really a continuation of the anterior interventricular sulcus. So here you will find blood vessels as well. Now when we look at the valves of the heart, okay, the heart has two sets of valves. The first set of valves are what we call atrioventricular valves. These are valves that separate, or basically control the flow of blood between the atria and the ventricles. So you have what's called a right atrioventricular valve. You also have a left atrioventricular valve. Now another name, or more common name, for the right atrioventricular valve is a tricuspid, because of the three cusps that are part of its anatomy. And then you look at the left atrioventricular valve. It has a couple of more common names as well. Sometimes you'll see this, call this the bicuspid, because of the presence of two cusps, or mitral valve. Okay, both these valves are anchored down, okay, to basically the inside of the ventricles by cord-like structures called chordae tendineae, and each chordae tendineae is attached to a series of papillary muscles. Right? Now the other two sets of valves are called semilunar valves. Okay, the semilunar valves basically control the flow of blood out of the heart itself. Okay, so the atrioventricular valves control the flow of blood from the atria to the ventricles, and when it comes to controlling the flow of blood out of the heart itself, this is where we're going to find semilunar valves. Okay, and we're going to have what's called a pulmonary semilunar valve and also an aortic semilunar valve. The pulmonary semilunar valve is found between the right ventricle and the pulmonary trunk, and the aortic semilunar valve is found between the left ventricle and the aorta here. So take a closer look at these valves. Okay, once again we have the right atrium, right ventricle. In between the two we will have, okay, our tricuspid valve right in this area. You can see the chordae tendineae. They anchor this valve down. Basically what the chordae tendineae do is it prevent the valve from prolapsing into the atrium here when the right ventricle contracts. And to reinforce this attachment, if you look at the base of the chordae tendineae, they're attached to these papillary muscles. Okay, so all these are little papillary muscles attached to the chordae tendineae. You have the same thing over here on the left side. So you have the left atrium, left ventricle. We have the bicuspid, the mitral valve here, anchored down by chordae tendidae, which are attached to papillary muscles as well. Now, when it comes to the semilunar valves, you can only see one of them here, and this is the pulmonary semilunar valve. Okay, pulmonary semilunar valve basically controls the flow of blood from that right ventricle into the pulmonary trunk here. Okay, so one of the things I definitely want you to be aware of, okay, is the flow of blood as it makes its way through the heart. Okay, in this slide here does a good job of summarizing, okay, all the points or all the places that blood moves towards as it makes its way through the heart. What I'm going to do is I'm going to use this diagram here, kind of erase what I did earlier. Okay, make sure you have a good understanding of how blood flows through the heart here. Okay, now basically where we're going to start at, we're going to start at the left atrium. Okay, left atrium receives blood returning from systemic circulation, and there are 3 blood vessels that feed blood into, not the left atrium, excuse me. I warned you not to do that. Okay, this is the right atrium. Okay, we have the right atrium, and the right atrium is what receives blood from the systemic circuit. And there are 3 blood vessels that feed blood into the right atrium. Okay, and the three blood vessels that feed blood into the right atrium include the superior vena cava. And this is blood returning from the head, neck, and upper extremities. We also have the inferior vena cava, okay, which is blood returning from the abdominal cavity, lower extremities, and parts of the thoracic cavity. And there's a third blood vessel that's not shown on here, but it's called the coronary sinus. And the coronary sinus is basically returning blood from the heart itself. Okay, so the superior vena cava, inferior vena cava, coronary sinus, they all basically drain blood from systemic circuit into the right atrium. Now, from the right atrium, blood's going to go into the right ventricle. Right atrium, right ventricle. And when blood is found on the right side of the heart, okay, blood will have a low oxygen level and will have a high CO2 level on the right side of the heart here. Now, as it does move from the right atrium, from the right ventricle, we pass through our first valve. Okay, this is our right atrioventricular valve. Okay, or our tricuspid valve. Now, from the right ventricle, okay, blood is going to be pumped out of the heart and into the pulmonary circuit. Okay, and the blood vessel that it's going to be pumped into is the pulmonary trunk. And this is an artery. Okay, the pulmonary trunk is an artery. And as blood moves from the right ventricle to the pulmonary trunk here, we pass through our second valve. This is our pulmonary valve, or what we call pulmonary semilunar valve. Okay. And then eventually the pulmonary trunk bifurcates into the left pulmonary artery and the right pulmonary artery, which you can't see on this diagram. Okay. And the right and left pulmonary arteries basically deliver blood to the right and left lung here. Now, what's unusual about these arteries, okay, an artery is any blood vessel that carries blood away from the heart. Most arteries have a high oxygen level and low CO2 level. However, this is an exception. We look at these arteries, okay, once again, these arteries have a low oxygen level, high CO2, which is opposite of most arteries. Now, blood eventually makes its way through the lungs, CO2 is dropped off, oxygen is picked up, and then once blood makes its way through the lungs, it will return to the heart through pulmonary veins. Okay, veins, any structure that returns blood to the heart here. And there are 4 pulmonary veins. There's 2 pulmonary veins from the right lung, there are 2 pulmonary veins from the left lung, and all 4 veins return blood to the left atrium. Okay. Now we look at the condition of blood on the left side of the heart. The left side of the heart, blood's going to have a high O2 level, it's going to have a low CO2 level. Okay, so from the left atrium, we'll go to the left ventricle. When we go from the left atrium to the left ventricle, we pass through our next valve, and this is the left atrioventricular valve, or the bicuspid or mitral valve. And then the left ventricle, when it contracts, it sends blood back into systemic circuit. Okay, now when the left ventricle pumps, it's going to pump blood in a superior direction into the ascending aorta. And when it's pumped into the ascending aorta, we'll go through our last valve. Okay, our last valve here is the aortic valve. Okay, and then it essentially after this point is now part of the systemic circuit here. So these are the major events that I want you to be aware of as far as blood and making its way through the heart. I do want you to be aware that when the left ventricle and right ventricle, when they pump blood, they pump it in a superior direction. So right ventricle has to pump blood in a superior direction into the pulmonary trunk, and then the left ventricle has to pump blood in superior direction as well into the ascending aorta. And one other thing I want to mention, I talked about these pulmonary veins earlier. These pulmonary veins are very unusual, and the pulmonary veins here have a high oxygen level and a low CO2 level. Most veins are just the opposite. Just like most arteries are the opposite what we saw with the pulmonary trunk and pulmonary arteries. In pulmonary arteries, we had a low oxygen level and we had a high CO2 level. That's opposite of most arteries here. One other thing I will point out is in fetal circulation, okay, blood does not move through the pulmonary circuit. Okay, so in fetal circulation, there's a bypass. Okay, a couple of bypass points so that blood does not go through the lungs. First bypass point is right here. In a fetus, there's an opening between the right atrium and the left atrium. Okay, and that opening is called the foramen ovale. Okay, and when blood gets into the right atrium, what it can do is it can go straight to the left atrium through the foramen ovale. Now, after birth, that foramen ovale closes, okay, and becomes the fossa ovalis. Okay, so the fossa ovalis is a remnant of the foramen ovale. Also, if blood, doesn't make it through that bypass and goes into the right ventricle, pulmonary trunk, in a fetus, there is an artery here that connects the pulmonary trunk to the aorta. Okay, now artery is called the ductus arteriosus. Okay, now after birth, okay, that closes. Okay, the artery closes and becomes a ligamentum arteriosum. Okay, but that's another bypass point. So just kind of excuse me, a couple side points I wanted to point out here when I have this diagram. Okay, and like I said earlier, this diagram does a good job describing the movement of blood through the heart here. Now, as soon as blood is pumped into the ascending aorta, okay, it'll run into a series of branches that will deliver blood to specific areas of the body. The first two branches of the ascending aorta, or the aorta in general, okay, is going to be the right-left coronary arteries. Okay, the right-left coronary arteries are going to carry blood to the heart itself. The blood has a high metabolic demand. Actually, 5% of cardiac output goes to the heart itself, and this is because of the high need of oxygen and nutrients that the heart has. So the first two branches of the aorta is the left coronary artery, okay, and the right coronary artery. Right. And then after that point, okay, there are several branches of each of these. Okay, so a couple branches of the left coronary artery include the anterior interventricular branch, circumflex branch, and then a couple branches of the coronary artery include the right marginal branch and the posterior interventricular branch. Okay, I'm going to have you learn a lot of these branches in A&P Revealed here, but to show you what we're looking at, here is the left coronary artery. This is the right coronary artery. Left coronary artery branches. Got a couple points here. One of the main branches is this. Okay, and this is the anterior interventricular branch. Okay, it supplies blood to a major part or major large surface area of the heart. And the other branch is your circumflex. Okay, circumflex kind of wraps around and makes its way to the posterior aspect. Now, the right coronary artery travels to the coronary sulcus. Okay, and you can see a branch here. We have the right marginal branch. It's one of those branches. And then on the back, here we are, kind of wrapping around. Another major branch is going to be the posterior interventricular branch of the right coronary artery. Okay, so those are a couple major blood vessels I want you to be aware of. Now, this branching continues, and one of the things that you'll see, I don't remember if your book talks about it a whole lot, but one of the things you'll see is all these blood vessels start to mix, okay, and exchange branching points, so to speak. All this branching is called anastomosis. Okay, anastomosis is basically a way for the heart to protect itself in case any of these small blood vessels become clogged, okay, with a embolus. I mean, we talked about that in the last chapter here. So let's say this blood vessel here becomes blocked. Okay, does that mean this tissue here is necessarily going to die off? And the answer is no, not if there is additional blood supply into this area. And like I said, that's called anastomosis. Now, if you have some type of blockage upstream, like for example, if you have a blockage in the left coronary artery, okay, then you're in big trouble. Okay, because this happens before all these branching points occur. And that's why another name for the left coronary artery, you'll see that often called the widowmaker. So if that becomes blocked, then someone's going to be in big trouble there. Okay, now blood flow to the heart is, when we look at the flow of blood to the heart, it's a little bit different from all other tissue types. Most tissue types, when the heart contracts, that's when they reach, that's basically when they receive the largest amount of blood. It's different in the heart. Okay, in the heart, when the heart relaxes, okay, when the heart relaxes, that's when the heart receives most of its blood. Okay, so when you talk about systemic tissue, when the heart contracts, it receives most of its blood. Now, the heart itself, when it relaxes, that's when it receives most of its blood. Now, 3 reasons for this. First of all, when the heart contracts, it compresses coronary arteries, okay, and that obstructs flow. Okay. Second, opening the aortic valve, okay, when the heart is contracting, blocks the opening of the coronary arteries. Okay, so look at this next slide here. Here is your openings to the coronary arteries, and this valve that we're looking at, this is the aortic semilunar valve. But when this aortic semilunar valve opens, okay, it opens when the heart contracts, these openings are blocked, okay, and that reduces blood flow. And also, when the heart relaxes, okay, what happens is there's backflow of blood in the aorta, okay, and that backflow of blood in the aorta basically enhances the flow of blood through those coronary arteries. Okay, so if this is the heart, this is the heart. Here is the aorta, and we have an opening for the right coronary artery, opening for the left coronary artery. When the heart relaxes, blood in the aorta flows backwards. Okay, and that blood kind of spills into the right and left coronary arteries here. Okay, so those are 3 reasons why the heart receives most of its blood, why the heart is relaxed. And once again, that's opposite of most tissue of the body here. Now, the heart is very sensitive to reduction in blood flow. Okay, and if there's some type of partial obstruction in a coronary blood vessel that leads to angina pectoris. Okay, and basically, if somebody has reduced blood flow, then the myocardium switches to anaerobic fermentation, which produces lactic acid, and that can produce some symptoms very similar to a heart attack. Now, if you have complete occlusion in the blood vessel, what will happen is the cardiocytes that are fed by that blood vessel will start to die off. Okay, and when tissue dies because of a lack of blood flow, that's referred to as infarction, and we're dealing with myocardial tissue here, so that's called myocardial infarction. And myocardial infarction is the clinical term for a heart attack. #1 killer in the United States today, right here, myocardial infarctions. Okay. Now, there is some protection, like I was talking about earlier, the arterial anastomosis. Okay, all those interconnections that we saw. But once again, if you have a blockage and a vessel is found upstream to those anastomoses, okay, then that can create a big problem. Now, drainage from the heart is going to be through the coronary veins, and there are 4 major coronary veins that I'll highlight here. We have the great cardiac vein. This is found in the anterior interventricular sulcus. We have the middle cardiac vein, which is found in the posterior interventricular sulcus. We also have a left marginal artery and coronary sinus. Okay, so you look at the anterior interventricular sulcus right here. Here's your great cardiac vein. Okay, now found somewhat close to it is you're going to have the left marginal vein, which is on this side. This is the back of the heart. And if you look at the posterior interventricular sulcus, you have the middle cardiac vein. Now, another name for the middle cardiac vein, this is also called the posterior interventricular vein. Now, eventually, all blood returning from the heart itself it drains into the coronary sinus. Okay, coronary sinus is found in the coronary sulcus. And this coronary sinus is what I was talking about earlier. Here I said blood returning from systemic circuit, okay, returns to the heart in the right atrium. There are 3 blood vessels that feed in the right atrium: superior vena cava, inferior vena cava. This is the 3rd one, the coronary sinus. Okay, and this is blood basically returning from the heart itself here. So make sure you know some of these major blood vessels are highlighted on these diagrams. Also make sure you work on those blood vessels with A and P revealed as well. Now if we take a look at the heart cells themselves, okay, heart cells are called cardiocytes. Okay, they are striated, they're short, they have branching points, they have one centrally located nucleus, and all cardiocytes are connected together by intercalated disc. Okay, and within those intercalated discs are a couple of junctions. You may remember there are desmosomes. Okay, desmosomes resist a pulling force, and also we have electrical junctions called gap junctions. Remember, gap junctions are just little tunnels that connect 2 cells together. And what these gap junctions allow for is for ions to flow in between cells. I'll talk about the significance of that here in a few minutes. Now, cardiocytes themselves, they don't divide. Okay, so if a cardiocyte dies because of some type of infarction, it's not going to be replaced. Okay, and that's why heart attacks can be so damning, is because of the inability of the heart to replace damaged muscle. So instead of muscle being regenerated, what's going to happen is scar tissue is going to take its place. Okay, remember fibrosis, okay, process of forming scar tissue, assuming somebody lives, okay, from their heart attack. So here are the cardiocytes. Okay, they are striated. Here's the intercalated disc. Okay, you see the branching points, and then if you look inside these intercalated discs, you see the desmosomes, and you also see the gap junctions. Once again, small little tunnels connect one cardiocyte to another here. And we look at some of the unique characteristics of heart muscle. Heart muscle is highly fatigue resistant. Okay, it can beat in a typical lifespan several billions of times. Okay, and during that time span, it never really becomes fatigued until maybe the very end here. But since it is fatigue resistant, it depends almost exclusively on aerobic respiration. Okay. Now compare that to a blood cell. Remember, a blood cell doesn't have mitochondria. Okay, so what does a blood cell depend on? Okay, a blood cell depends exclusively on anaerobic respiration. Now, what allows cardiac muscle to depend on aerobic respiration, first of all, they have a lot of myoglobin, they have a lot of glycogen, there are huge mitochondria found within cardiocyte. In fact, 25% of the volume, okay, of 25% of the volume of cardiocyte is from the mitochondria. And cardiocytes are very flexible in terms of what they use as a fuel source. 60% of their energy comes from fatty acid metabolism, 30% from glucose, but also the heart is able to derive energy from ketone bodies, from lactic acid, and from amino acids. Okay, so since they're so flexible in terms of what they use for fuel, cardiocytes are rarely in danger of not having enough energy. Okay, now what they are susceptible to is not having enough oxygen. Now, as we saw, the cardiac tissue itself receives 5% of the cardiac output. Okay, so all these characteristics make the heart extremely fatigue resistant. And like I said, it does not fatigue during a lifetime until maybe the very, very end here. Okay, now the next thing we're going to look at is the conduction system of the heart. Basically, a conduction system is a system that spontaneously generates action potentials and allows the heart to beat on a regular basis. And we're going to look at the different parts of the conduction system. Basically, the heart is self-exciting. You can cut off all nerve supply to the heart and it will continue to beat on its own. You can take the heart out of the body. If you place it in an environment where it has oxygen and nutrients, it will continue to beat as well. So I have the different parts of the conduction system listed on this slide here. What I'm going to do is just use the diagram to go over these different components. Now where it starts is it starts with the SA node. SA node is found right here in the right atrium. Okay, this is called the sinoatrial node, and this is also called the pacemaker. Okay, and the pacemaker is what generates action potentials spontaneously at a regular interval. Now, the pacemaker itself, it will generate around 100 action potentials per minute. Okay, so that means if the heart wasn't influenced by the nervous system, it would have a heart rate, an intrinsic heart rate of 100 beats per minute. But at rest, a typical heart rate is about 72 beats per minute. Okay, so what part of the nervous system do you think influences the heart at rest? Well, that's going to be your parasympathetic nervous system. Okay, you have what's called parasympathetic tone. Okay, parasympathetic nerves that come from vagus basically slow the SA node down. But if you leave the SA node alone, okay, it generates 100 action potentials per minute. That's kind of the inherent rate of the SA node. Now, as soon as the SA node generates an action potential, that action potential is carried quickly to all the cells in the atrium. Okay. Now, how is this signal carried quickly to all of the cells in the atrium? Well, that's because of gap junctions. Okay. All these cells are interconnected because of the gap junctions. And this is an important characteristic because when one cell in the atrium contracts, they all need to contract. Okay, so the right and left atrial cells, they need to contract at the same time, so this message has to be delivered quickly here. Okay, and that's all because of the gap junctions that we were talking about earlier. Now, another area where this action potential is going to go is it's going to go to the atrioventricular node, AV node. Okay, this is the AV node right here. The AV node is a speed bump, okay, and it's going to slow down this action potential. Now, where it's going to go next is into the ventricles once it goes to the AV node. And after the AV node, you have what's called the atrioventricular bundle. This is the bundle of His. Another name for this is the bundle of His, kind of an older term for this. This AV bundle here, this is the only electrical connection between the atrium and the ventricles. Okay, basically, the atria and the ventricles are separated by the fiber skeleton of the heart itself, and the fiber skeleton basically insulates the atria from the ventricles electrically. Okay, so the only electrical connection between the two is this AV bundle, and from there, the AV bundle will bifurcate and split into the right and left bundle branches. So right bundle branch, left bundle branch. The right and left bundle branches carry this action potential down the interventricular septum toward the apex. Now, when we get down here close to the apex, what's going to happen is we're going to have branching points that form Purkinje fibers. And Purkinje fibers will quickly carry this impulse to the cardiocytes found in the ventricles. Okay? And one important note here is notice that this impulse goes to the apex first. Okay? And the reason for that is, if you remember, the pulmonary trunk is found here, the aorta is found here. So when the ventricles contract, they have to move blood in a superior direction. Okay? So by taking this impulse to the apex first, what happens is these cells start to contract first, and then the cells above it will follow it. And this will essentially form a wave of contraction that forces blood in a superior direction. Okay, so those are the major parts. Okay, the major parts of the conduction system I do want you to be aware of. Kind of go over it here real quick. We have the SA node. From the SA node, we go to all the cells of the atria through gap junctions. We also go to the AV node. AV node, once again, is our speed bump. Why do we have a speed bump? Well, when the atria contract, okay, we don't want the ventricles contracting. Okay, so what the speed bump does is gives the atria a head start. Okay, so they don't contract at the same time as the ventricles. And then we go from the AV node to the bundle of His. Bundle of His divides into the right and left bundle branches. Right and left bundle branches take it to the apex. Apex branches out to Purkinje fibers. And then the wave of contraction is carried in a superior direction. Now, one thing about the pacemaker, remember, our pacemaker is what? That's the SA node. Okay, I do want to point out that any of these components can serve as a pacemaker if the SA node is damaged. So if the SA node is damaged, the AV node can take over that role, The bundle of His can take over that role. The Purkinje fibers can take over that role. But their inherent rate is much slower. Okay, I talk about the inherent rate of the SA node. The inherent rate of the SA node is 100 action potentials per minute. The inherent rate of something like the AV node or the Purkinje fibers is much smaller. Okay, we're talking about 30, 40, maybe 50 action potentials per second, which would give us a heart rate around 40 beats per minute. Okay, a type of heart rate that we call bradycardia, basically a slow heart rate. Now, if any of these other components take over the pacemaking duties, that's called an ectopic pacemaker. Okay, ectopic just means misplaced. Okay, this happens when there's some type of damage to the SA node, and this is usually when somebody has to have some type of pacemaker set in. Okay, so this next slide basically discusses what we went over. Now, when it comes to nerve supply to the heart, the nerve does, like I said, you can cut off all nerves to the heart and it still beat on its own. What the nerves do, the nerves just modify the heart rate. Okay, so as you may guess, sympathetic nerves increase the heart rate, also increase the strength with which the heart contracts with. And we look at parasympathetic nerves, slows down the heart rate. Make sure you know what nerve carries parasympathetic innervation to the heart. You're an expert on this by now, and that is the vagus nerve. Okay. And one thing I do want to mention, the vagus nerve, okay, influences the SA node, influences the AV node. However, the vagus nerve really doesn't influence the myocardium. And it really has no influence on the ventricles. Okay. So when we look at the ventricles of the heart, this is one area where we don't find dual innervation. Most areas of the body we have dual innervation in terms of a sympathetic input and a parasympathetic input, but when it comes to the myocardium, especially within the ventricles of the heart, there's very little parasympathetic input. Now we look at the events, okay, in a heart cycle. First of all, we have a phase where the heart muscle is contracting. Either the atrial muscles are contracting or the ventricle muscles are contracting. When any muscle contracts, that's referred to as systole. Okay, and then you also have a period in which the muscles relax. Okay, when the muscles relax, that's diastole. Okay, so you have ventricular systole or atrial systole, and then you have atrial diastole or ventricular diastole. Now, as I said before, normal heart rate is around 72 beats per minute. Okay, and we go back and forth between systole and diastole. That's because the vagal tone that I was referring to earlier on. Also, a little bit on the ectopic focus. Okay, remember that's when some component of the conduction system takes over the role of pacemaking other than the SA node. And we look at abnormal rhythms. Okay, it has some type of arrhythmia. You can have atrial flutter. It's basically where the atria contract at a very rapid rate. Okay, 200 to 400 times per minute. Okay, you also have ventricular fibrillation. This is a very serious condition where the ventricles are basically out of order. Okay, they have electrical chaos going on, and there's not any type of unison found within the ventricles here. Okay, this is where somebody has to have a defibrillator used in order to basically lift. Okay, this can kill somebody very quickly if the ventricles go into fibrillation here. Okay, now next thing we're going to look at is basically an action potential of a cardiocyte. Okay, we looked at action potentials of skeletal muscles in EMP1. So here's a typical action potential of a muscle. You have your resting membrane potential. When a muscle is stimulated to contract, you have a phase of depolarization. Remember, during depolarization, we have sodium rushing into the cell, and that's followed by repolarization of the skeletal muscle cell. And that's basically created by potassium rushing out of the cell. Okay, so when a skeletal muscle cell depolarizes, sodium rushes in. When it repolarizes, potassium rushes out. Only reason I'm talking about this now is to put it in perspective as we look at an action potential for a cardiocyte. Okay, an action potential for a cardiocyte is a little bit different here. First of all, we have our resting membrane potential. Okay, and once a cardiocyte generates an action potential, we have a wave of depolarization. Okay, This wave of depolarization is caused by sodium, okay, rushing into the cell, just like we saw with skeletal muscle. Now what's different is cardiocytes have a plateau, okay? And what this plateau does is it basically extends, okay, the time it takes for an action potential to run through a cardiocyte. Now what creates this plateau is another type of channel known as slow calcium channels. Okay, and what happens at point 4 is slow calcium channels open. When slow calcium channel is open, you may remember calcium has a higher concentration outside of the cell than inside the cell. Calcium rushes in. Okay, calcium rushes in and causes the cell to remain depolarized for a longer period of time. Okay. Now after this point, everything else is going to be the same. We're going to have repolarization, which is potassium rushing out of the cell. Now what's the point of this plateau period? The point of this plateau period is to extend the absolute refractory period. Okay. This is the time period in which a muscle cannot contract regardless of the stimulus strength here. And what this prevents by extending the absolute refractory period, it prevents tetany within cardiac muscle. Okay. Tetany in a cardiac muscle is life-threatening condition because if a muscle can't relax, it can't receive blood. Okay. It's going to be if the heart muscle can't relax and the heart can't receive blood. If the heart can't receive blood, then it can't pump it out to cells in the systemic circuit. Okay, and the cells will start to become hypoxic. And this plateau, okay, I definitely want you to remember, is caused, okay, by these slow calcium channels. So these slow calcium channels is something that we didn't see when we're going over skeletal muscle. This is also why changes in blood calcium levels have an impact on the heart. Okay, and that's one of the reasons why it's important to regulate blood calcium levels, and we saw that a couple times in this class. Okay, now another action potential I want you to be able to identify is action potential of a pacemaker cell. Okay, so go to the SA node. Okay, the cells in the SA node, those are your pacemaker cells, and one of the characteristics of the cells is that they are self-exciting. Once again, they generate action potentials on their own without input from the nervous system. Now they can be modified by the nervous system, but they don't need the nerves to generate their own action potentials. Now, to understand how they do this, you need to understand a action potential for a pacemaker cell. And there's different types of channels involved here. First of all, we have a slow sodium channel. Okay. Sometimes in other physiology books you'll see this called an F-type sodium channel. F means funny. Okay. And what's unusual about this sodium channel here is more likely to open the more negative the membrane potential is. And this is different from all sodium channels. Okay, all sodium channels, the less negative the membrane potential is, the more likely they're going to be open. But with these slow sodium channels, the more negative the membrane potential, the more likely it will be open. So when we're down here around 60 millivolts, these slow sodium channels are open and sodium rushes in. Okay, as sodium rushes in, it depolarizes the cell until it gets to threshold. When we get threshold, the pacemaker cell is going to depolarize, and the depolarization is going to be caused by the entry of sodium and calcium. Okay, pacemaker cells have what's called a fast calcium channel, and these fast calcium channels play a role in the depolarization of these cells. So cell membrane depolarizes, get to the apex here, and then we have our regular potassium channels open. Okay, and as potassium channels open, potassium rushes out. It leads to repolarization. As we continue to repolarize, we drop below our threshold. Notice what happens again. When we get down to -60, when we get to -60, what opens again? What opens again is the slow sodium channels. Sodium rushes in. It's kind of like a positive feedback, kind of feeds itself. Okay, and that's why your pacemaker cells are self-exciting. Okay, and they can generate their own action potentials. If we're talking about cells in the SA node, they do this 100 times per minute on their own. Now, when we have vagal tone, okay, the parasympathetic nervous system basically slows this down. It slows it down to something like 72 times per minute, and that gives us a corresponding heart rate of 72 beats per minute. So make sure you can recognize and describe the action potential for a cardiocyte, also the action potential of a pacemaker cell as well. Now, all of these electrical events leave a footprint, so to speak. Okay, when we look at ions moving in and out pacemaker cells, cardiocytes, okay, that leaves an electrical footprint that can be detected with an electrocardiogram. Okay, ECG. You may see they call this an EKG. Okay, the German word for cardio begins with a K. Okay, that's where that comes from. An electrocardiogram is a very useful instrument for evaluating the health of the heart. So if somebody has a heart attack, there are signs that show up on an EKG. If somebody's having issues with the conduction system, that shows up on an EKG. Bradycardia, tachycardia, those are all things that show up on an EKG as well. All I really want you to know here are the three main line deviations associated with an ECG and what those deviations correspond with. Okay, so the three main deviations I want you to be aware of. There's a P wave, okay, there's a QRS complex, okay, and there is a T wave. Okay. So we look at all three of these. Here's the T wave. Okay, when we look at the T wave, this is basically when the SA node is firing and the atria are depolarizing. Because during the P wave, the atria are depolarizing, they're preparing to contract. Now, the next deviation is much larger. Okay, you have what's called a QRS complex. And what's happening here is the ventricles are depolarizing. Okay, the ventricles are preparing to contract. And then the third deviation is a T wave. Okay, when we look at the T wave, the ventricles are repolarizing. They're going through repolarization, which means the ventricles are preparing to relax. Okay, and those are your three main line deviations. P waves, atria are depolarizing, QRS complex, the ventricles are depolarizing, in the T wave, the ventricles are repolarizing. You may ask, well, where is atrial repolarization? Well, when the atria repolarize, that happens at the same time as the QRS complex. Okay, and it's kind of hidden within that QRS complex. And this is what a normal ECG looks like. Okay, and as I said, anytime there's some type of, many different types of pathology show up on an ECG. You can see a normal one here. Here's a heart block. This can be a heart block. We have a nodal rhythm, and no SA node activity, premature ventricular contraction, ventricle fib that we're talking about earlier. I'm not going to have anything like this on a test and have you tell me what it is. I just want you to know what a normal one looks like. What does a normal one look like? Normal one look like, and be able to describe these three main line deviations. Okay. Now, the next part, we're going to go over the different vents of a cardiac cycle. When we talk about a cardiac cycle, it's one complete contraction and relaxation of all four chambers. Okay, so when the atria are in systole, the ventricles are in diastole. Okay, and then after that, the ventricles go in systole and the atria go into diastole. And after that, there is what we call a quiescent period, and this is where all four chambers are relaxed at the same time. And so those events constitute a cardiac cycle. Now, when it comes to what determines blood flow, the direction of blood flow through the heart, there are two important factors. Okay, first of all, you have pressure. Okay, pressure causes fluid to flow. Basically, what you need to remember: fluid always moves from high pressure to low pressure, just like air. And resistance. Okay, resistance opposes the flow of fluid. Now, another important thing to remember here is Boyle's law, and I don't mean to bring chemistry in this class, but I'm going to have to just for a few seconds. Remember, Boyle's law is an inverse relationship between pressure and volume. Okay, the inverse relationship between pressure and volume. So when the volume of a ventricle decreases, its pressure increases. Okay, and just the opposite, when the volume of the ventricle increases, okay, its pressure is going to decrease here. Okay, so what we're going to look at is the major events of basically one cardiac cycle, and we're going to look at the left side of the heart only. We're going to look at what happens between the left atrium, left ventricles. Even though we're going to look at the left side of the heart, basically the same things are going to happen on the right side of the heart, just with different pressures here. And this diagram is a pretty good summary of these vents here. And I'm going to go through this diagram. I'm going to go through the top part of this diagram. That's the most important part I want you to be aware of. And I basically have a description of this diagram on all these slides here. Okay, but on this slide, everything's kind of enlarged. It makes it a little bit easier to see. And as with any cycle, we can start at any point. Where I'm going to start here is at the beginning of ventricular systole. Okay, so what we're looking at, look at the lines. Okay, the red line is left atrial pressure, the black line is left ventricular pressure, and the red line at the top, that's aortic pressure. So remember, the left ventricle is going to pump blood into the aorta here. Okay, so at the beginning of ventricular systole here, okay, that ventricle is going to have a set amount of blood. Okay, now the amount of blood in the ventricles at the beginning systole is referred to as the end diastolic volume. Okay, so when the ventricle is done relaxing, the volume of blood in there is your end diastolic volume. Now, as soon as the left ventricle begins to contract, okay, what do you think is going to happen to its pressure? Okay, its pressure is going to start to build up. Now, very quickly, it's going to build up enough pressure so that it exceeds the pressure within the left atrium. And when left ventricular pressure exceeds left atrial pressure, what will happen is the left atrioventricular valve will close, okay, or the mitral valve or bicuspid valve. Okay, so when left ventricular pressure exceeds left atrial pressure, you have closure of the mitral valve. Now that left ventricle will continue to contract, okay, and in order to open up the aortic semilunar valve, it has to generate enough pressure so that it exceeds aortic pressure. Okay, so when the pressure in the left ventricle exceeds aortic pressure, that's when your aortic semilunar valve is going to open. So notice, here is our aortic pressure. Okay, and as the ventricle contracts, okay, its pressure builds and builds and builds. Okay, now keep in mind both valves are closed. Okay, since both valves are closed, there's not going to be any net change of blood. Okay, blood's not entering or leaving. Since there's no change in blood, this time period here between here and here, this is called isovolumetric contraction. Okay, so isovolumetric contraction is when the left ventricle is contracting, both valves are closed, and it will continue to contract until the pressure in the left ventricle exceeds aortic pressure. Now, when the pressure in the left ventricle exceeds aortic pressure, the aortic semilunar valve opens up. Okay, and when it opens up, you'll have ejection of blood from the left ventricle, okay, into the aorta. Okay, and that's what you're observing here. Okay, during this time period, that valve is open, okay, and blood is moving from the left ventricle into the from the left ventricle into the aorta. Now, eventually, that left ventricle is going to start to relax. Okay, as it relaxes, its volume increases. As its volume increases, what's going to happen to its pressure? Its pressure is going to drop. Okay, now as its pressure drops, eventually its pressure will drop below the pressure in the aorta. And when the pressure in the left ventricle drops below the pressure in the aorta, what's going to happen is that aortic semilunar valve closes. Okay, and when the aortic semilunar valve closes, it will continue. Okay, the left ventricle will continue to relax here, and that's what you have on this line. Left ventricle is relaxed, aortic valve is closed. Okay. Also, before I move on, one of the things that happens when that aortic semilunar valve closes, there's a backflow of blood, okay, that moves toward the left ventricle. Okay, and we saw this earlier when I was talking about the filling of the coronary arteries. And because of that backflow of blood, you see a small increase in aortic pressure. The small increase in aortic pressure is referred to as a dicardic notch. That's just from the backflow of blood once that aortic semilunar valve closes. Okay, so back to this line here. Left ventricle continues to relax. As it relaxes, its pressure drops. Now eventually, the pressure in the left ventricle will drop below the pressure in the left atrium. Now when the pressure in the left ventricle drops below the pressure in the left atrium, what's going to happen is that AV valve will open back up. And when that AV valve opens back up, then blood is going to flow, okay, from the left atrium into the left ventricle. But between these 2 points, okay, this is where the aortic valve closed. This is where the mitral valve opened. And the point between where the aortic valve closed and the mitral valve opened, there was no change in blood volume. And since there's no change in blood volume, we call this isovolumetric relaxation, okay, within that short time period. Now, once it opens, okay, then blood once again will start to flow from the left atrium to the left ventricle. And most of the blood that moves from the left atrium to left ventricle is passive, okay. And the reason that's passive is just because of location. Okay, we talk about the anatomy. The atrium's right above the left ventricle, and gravity does most of the work here. Now, not all the blood's going to be pumped out. Okay, when we talk about the left ventricle, not all the blood's pumped from the left ventricle into the aorta. So the amount of blood that's left in the left ventricle at the end of systole, that's called your end systolic volume. Okay, so what do we begin with? Okay, what we begin with was end diastolic volume. What we finished with is end systolic volume. The difference between these 2 volumes is called stroke volume. Okay, and the stroke volume is actually the amount of blood that leaves the left ventricle. Okay, stroke volume is the difference between end diastolic volume and end systolic volume. Okay, so now we're in diastole. As I said before, diastole is where the ventricle is going to receive blood from the left atrium, and most of this filling is passive just because of gravity. So you have a brief period right here. Okay, this is referred to as rapid ventricular filling. Then that slows down to a period called diastasis. And then finally, the left atrium contracts. Okay, when the left atrium contracts, it contributes the last small amount of blood that's going to go into the left ventricles here. Okay, so you have 3 phases of filling. You have rapid ventricular filling, followed by diastasis, followed by atrial systole. And we get to this point here, we start all over. Okay, start all over. Ventricle starts to contract, closes the bicuspid valve, and we start the process over again. Okay, so a lot going on in this diagram. This diagram will be on your test. Okay, so make sure you can identify the different parts. Be able to make sure you can read the changes in pressure, the changes in volume, etc. here. Okay, so as I said, during ventricular ejection, not all the blood leaves. Okay, but the blood that does leave, once again, is the difference between end systolic volume, end diastolic volume, and end systolic volume. It's called your stroke volume. Okay, average value for stroke volume is around 70 milliliters. Okay, in the percentage of end diastolic volume that's actually pumped out, it's called ejection fraction. Okay, so for a person at rest, okay, roughly 54% is injection fraction. So 54% of blood in the left ventricle actually leaves. Okay, it becomes part of the stroke volume. Now, when you exercise, that increases. That can increase up to 90% when your heart starts to contract with more strength. So to put some numbers to this, show you where the numbers are coming from. Essentially, we have our end diastolic volume. You have your stroke volume. So we start with 130 millimeters of mercury, and we pump out 70 millimeters of mercury when it does contract. Then your end systolic volume is going to be 60 milliliters. Okay, and the 60 milliliters will be the starting point for the next cardiac cycle. Okay, so the next cardiac cycle, 30 more milliliters will be added through passive, through passive means I was talking about earlier, and then another 40 milliliters through atrial systole. Okay, so make sure you know what end diastolic volume means, end systolic volume means. Make sure you know what stroke volume means, and so forth. So how long does all this take? Well, it takes me about 20 minutes to go over it, but for one cardiac cycle, atrial systole lasts for about 0.1 seconds. Ventricular systole lasts for about 0.3 seconds. Then you have a quiescent period that lasts for about 0.4 seconds. Okay, so the total time it takes for one cardiac cycle for a person at rest is 0.8 seconds. One thing I'll note that I will come back to in the next chapter is if you compare systole, if you compare systole here to diastole, okay, we have about 0.3 seconds. Okay, 0.3 seconds of ventricular systole. The rest of it's going to be diastole. Okay, so diastole lasts longer than systole. And I'll come back to the significance of that when we're talking about blood pressure in the next chapter here. Okay, so during all these events, there are sounds that can be generated by the heart, and we can listen to those sounds through auscultation. Okay, and the two sounds that are kind of classic description are the lub, dub. Okay, so the lub sound, the first sound, is associated with the closure of the AV valves. Okay, the dub sound, the second sound, is associated with the closure of the semilunar valves. They don't know exactly what causes the sounds. They just know it's associated with the closure of AV valves for the lub sound and closure of the semilunar valves for the dub sound here. Now, if there's some type of issue with the valves, okay, either the valves don't open don't open completely, or they don't close completely, that can lead to some type of murmur. Okay, murmurs is any abnormal sound produced by regurgitation of blood. So you have valvular stenosis. Okay, opening is constricted. You can have a mitral valve prolapse. Okay, mitral valve prolapse is when the mitral valve actually goes into the left atrium when the left ventricle contracts. So any of these events can lead to some type of heart murmur. Now, when it comes to congestive heart failure, I definitely want you to have a good understanding of the difference between left side failure and right side failure. First of all, congestive heart failure results from failure of either ventricle to eject blood effectively. Okay, so in other words, the ventricles can't keep up with the demand. Now, if somebody has left ventricular failure, okay, what will happen is the left side can't keep up with the right side. Okay, so normally in a healthy person, the amount of blood that's pumped out of the right side is going to be equal to the amount of blood that's pumped out of the left side. So if you have left ventricular failure, the left side can't keep up with the right side, so blood is going to back up in the lungs, and that's going to lead to pulmonary edema. Okay. So this can happen if somebody has high blood pressure for a number of years. If somebody has high blood pressure, the heart has to work extra hard to pump against that pressure, and eventually starts to fatigue and can't keep up. Now, when edema in the lungs develops, it makes it very hard to exchange oxygen, okay, and you have shortness of breath, also a sense of suffocation. Now, the other type of heart failure is right ventricular failure. Okay, and if somebody has right ventricular failure, then basically the right side of the heart can't keep up with what's coming back from systemic circuit. And if it can't keep up with what's coming from systemic circuit, blood is going to back up, and it's going to build up blood pressure. And if you build up blood pressure within the veins, that's going to lead to edema. Okay, so you can have edema in the abdominal cavity, ascites, we saw that before. It can cause distension in the jugular veins, swelling in the fingers, especially swelling in the ankles and feet. Okay, if somebody has congestive failure of the right side of the heart, okay, their ankles will become extremely swollen. Okay, actually, if you touch the area that's swollen and leaves a little indentation, that's called pitting edema. Okay, it's a classic sign of right side congestive heart failure. Just look around when you're out in the community. That's something that's very easy to see, the swelling of the ankles and the feet there. Okay, so pulmonary edema, it's failure of the left side of the heart. Systemic edema, that's going to be failure of the right side of the heart. Okay, now the amount of blood that the heart pumps out on a per minute basis, okay, that's referred to as cardiac output. Okay, and cardiac output has a very simple formula: heart rate times stroke volume. Okay, and an average cardiac output is 5 liters. You may remember that's the average volume of blood. Okay, so at rest, blood makes its way around, okay, the circulatory system once per minute. Now, if you start to exercise, that can increase up to 21 liters per minute. And if you have somebody that's in really good shape, a world-class athlete, that can increase up to 35 liters per minute. Now, cardiac reserve is the difference between a person's maximum and resting cardiac output. If somebody is in horrible shape, or has some type of, well, I shouldn't say that. If somebody has some type of congestive heart failure, usually that cardiac reserve is 0. Okay, and basically at rest, their heart is working as hard as it possibly can. Okay, now every time the heart pumps, okay, it creates a wave of pressure that travels through the blood vessels, okay, and it's felt as a pulse in the arteries. Okay, the number of pulses is equal to the heart rate, which an average heart rate around 72 beats per minute, like I said, for a person at rest. If somebody has a resting heart rate above 100, that's referred to as tachycardia. If somebody has a resting heart rate below 60, that's bradycardia. I want to be careful with bradycardia because some people who are in really good shape, okay, have a low heart rate, okay, a resting heart rate that's lower than 60, maybe in the 50s or the 40s. Somebody like Lance Armstrong in his prime had a resting heart rate, I think that was like 36 or 38 beats per minute. That's fine, that's normal. What we're talking about here is somebody with a congestive heart failure, somebody can't keep up and they have a very low heart rate. That's what bradycardia is really used for. Now, anything that increases heart rate is a positive chronotropic agent. Anything that decreases it is a negative chronotropic agent. So we look at, first of all, where heart rate is regulated. Okay, heart rate can be regulated by the autonomic nervous system. I do want to emphasize autonomic nervous system does not initiate the heartbeat, it just modifies it. Okay, the SA node is what's going to initiate the heart rate here. Now, the center for regulating heart rate is in the cardiac center, okay, which is in the reticular formation, the medulla oblongata. Okay, you may remember that from the last unit. So, if the heart rate needs to speed up, okay, this cardiac center is going to activate sympathetic nerves. If the heart rate needs to slow down, it's going to activate vagus nerves. Okay, so sympathetic nerves increase, parasympathetic nerves are going to decrease the heart rate. Now, some of the information that the cardiac center uses to evaluate heart rate, first of all, uses blood pressure. Okay, receives information regarding blood pressure. They're called baroreceptors. Baroreceptors constantly send information to the cardiac center about the blood pressure. It's also there's chemoreflexes, okay, or chemoreceptors. Chemoreceptors are found in the aortic arch, carotid arteries, and the medulla. They monitor pH, CO2, O2 levels. Now, these things have a more potent impact on the rate of respiration, as we'll see in a little while, but they do influence heart rate. So, for example, if pH levels drop, becomes too acidic, CO2 levels increase, those two things are related. So, for example, if you have high CO2 levels, that's hypercapnia. If it becomes too acidic, acidosis. They both stimulate an increase in the heart rate. Now, if oxygen levels slow down, somebody becomes hypoxic, they actually cause the heart rate to slow down. Okay, so too much CO2, too much acid, increase in heart rate, not enough oxygen, that causes the heart rate to slow down here. Just review the sympathetic nerves. I think you guys are pretty comfortable with that by now. All sympathetic nerves are adrenergic. They release norepinephrine, and norepinephrine binds to beta receptors. Okay, binds to beta receptors, and this can help increase both the contraction strength, also the rate of contraction, and the rate of relaxation as well. Parasympathetic nerves, remember, are cholinergic. Cholinergic nerves release ACH, and on the heart, ACH binds to muscarinic receptors, causes the heart rate to slow down. I do want to remind you, parasympathetic nervous system has little influence on the ventricles, especially the myocardial cells in the ventricles. And also I want to remind you of vagal tone. So what is the inherent rate of the SA node? The inherent rate of the SA node is 100. Resting heart rate is 72. Okay, so there's constant parasympathetic input going into the SA node at rest here. Some additional chronotropic agents, nicotine, thyroid hormones, caffeine, they all speed up the heart rate. Electrolyte balance also influences heart rate. The one I really want you to be aware of is calcium. If you have hypercalcemia, that decreases heart rate and contraction strength. Hypocalcemia increases heart rate and contraction strength. Potassium has an influence as well. Okay, actually pretty important influence, but the main thing I want you to be aware of is calcium. Okay, so those are all things that influence heart rate. Now, what influences stroke volume? Okay, so go back to cardiac output once again. Cardiac output equals heart rate times stroke volume. So anything that increases either heart rate or stroke volume increases cardiac output. Anything that decreases them decreases cardiac output. And when we look at what influences stroke volume, okay, there are three variables I want you to be aware of. We have preload, okay, we have contractility, and we have afterload. Okay, all three of these factors basically can influence a stroke volume. Okay, so an increased preload or contractility increases stroke volume. An increased afterload actually decreases stroke volume. Okay, so I'll explain why here in a second. First of all, look at preload. Okay, preload is the amount of tension in the ventricles in the myocardium before it contracts. Okay, and basically increased preload or increased tension causes an increased force of contraction. Now, there's a very famous law of cardiac physiology I want you to be aware of that really describes preload, and that's the Frank-Starling law of the heart. Frank-Starling law of the heart. Okay, so with that, basically what the Frank-Starling law of the heart says is whatever amount of blood goes into the heart has to be pumped out of the heart on a per minute basis. So if 5 liters of blood goes into the heart every minute, 5 liters of blood must be pumped out of the heart every minute as well. So stroke volume and end-diastolic volume are directly proportional. When end-diastolic volume increases, stroke volume has to increase as well. Okay, so here we have a graph of stroke volume versus end-diastolic volume. As end-diastolic volume increases, your stroke volume is going to increase as well. Now, what develops this tension? Okay, the more blood that goes into the myocardium, okay, the more tension that's going to develop within those muscle cells. And when those muscle cells develop more tension, they're going to contract with more strength. When they contract with more strength, you're going to have an increase in your cardiac output. And this has everything to do with the overlap between actin and myosin. You may remember this diagram from AMP1 here. Remember, actin and myosin, they have an optimal amount of overlap to where they can generate the strongest possible force of contraction. Okay, so you think of the biceps. The biceps can be extended. Okay, the biceps are extended. There's not much overlap between actin and myosin. The bicep can be almost fully contracted. Okay, the bicep is almost fully contracted. There's a lot of overlap, and then the biceps can be kind of in a position between the two, where we have an optimal amount of overlap. And when there's an optimal amount of overlap, this is when the biceps can generate the strongest possible force of contraction. Okay. Now, in the heart at rest, okay, heart at rest, there's a lot of overlap. Okay, there's a lot of overlap. When there's a lot of overlap, it can't generate the maximum force. Okay, it doesn't have to. Okay, because there's not much blood going into it. There's only about 5 liters going into it on a per minute basis. Now, when somebody exercises, what happens is more blood goes into the heart. When more blood goes into the heart, it stretches the cardiocytes. And when it stretches the cardiocytes, it stretches them to a position where it has the optimal overlap. Okay? And when it has the optimal overlap here, then it can generate the strongest possible type of contraction here. That's the Frank-Starling law of the heart. It has everything to do with the overlap between actin and myosin. And that's your preload. Preload basically means the more blood that goes in the heart, the more tension those muscle cells develop. The more tension those muscle cells develop, the stronger their contraction strength is going to be. Okay. Next is contractility. Contractility refers to how hard the myocardium contracts at any given end-diastolic volume. Think of this as contraction strength on top of the Frank-Starling law of the heart here. So here, this line follows the Frank-Starling law of the heart. Increase in end-diastolic volume, increase in contraction strength. But at any point, overriding factors can basically increase this force. Okay, so a good example is sympathetic stimulation. Sympathetic stimulation can increase the force of contraction beyond its normal line here. And when you increase the force of contraction beyond the normal line here, beyond the Frank-Starling line here, that's called contractility. Okay, so we look at some agents okay, that can increase contractility. First of all, anytime we're talking about contractility here, we're talking about anything that influences contractility. We're talking about inotropic agents. Okay, chronotropic is heart rate. Okay, inotropic is contraction strength. So you have positive inotropic agents. They all increase contractility. Hypercalcemia, catecholamines, okay, glucagon. Okay, you have a drug here called Digitalis, okay, which is given to people who have congestive heart failure. We also have negative inotropic agents, okay, hypocalcemia, okay, in the vagus nerve. Okay, the vagus nerve has effect on the atria, but very little on the ventricles once again here. Okay, and then finally the last factor is afterload. Basically, afterload, the higher the afterload is, okay, the lower the stroke volume is going to be. Basically, what afterload is blood pressure. Okay, so if somebody has high blood pressure, there's high afterload. High afterload decreases stroke volume, and therefore it makes the heart work harder in order to make up for that. Okay, so high blood pressure, okay, increases afterload. Also, you know, afterload is a factor for the right side of the heart. Okay, and the right side of the heart is going to be affected by what's going on in the lungs. So you have some type of restrictive pulmonary, it's going to be some type of restrictive lung disease. Okay, that can increase afterload. Also, I want you to be aware of the term cor pulmonale. This is right ventricular failure due to obstructive pulmonary circulation. Okay, so somebody has emphysema, chronic bronchitis, black lung disease that increases afterload, that makes the right side of the heart work harder. And when the right side of the heart starts to work harder, eventually it will fail. Okay, when it fails because of some type of lung issue, that's cor pulmonale. Okay, that's a term I want you to be aware of. Okay, the last part, the chapter goes over a few things on coronary artery disease, you know, constriction of the coronary arteries. Obviously, one of the main causes of this is atherosclerosis, okay, accumulation of lipid deposits, greatly reduced blood flow. Okay, so coronary artery can look like this. This is the normal lumen of the blood vessel. Notice most of this is filled with fat. Okay, and then what's left is the present lumen. Okay, so if you're trying to get blood to your cardiocytes in this cell of space you have to work with, it's not a good deal. And it's going to make climbing a flight of stairs somewhat difficult. Okay, but that's what atherosclerosis does. And eventually you can have complete occlusion, and that can lead to myocardial infarction. Now, major risk factors for atherosclerosis: high LDL levels. Okay, also, certain individuals are born with genetic disorder where they lack receptors for LDL. Somebody lacks receptors for LDL. That leads to familial hypercholesterolemia. If they're heterozygous, they may have a heart attack by 35. If they're homozygous, they may have a heart attack by the age of 2 because of coronary artery disease. Now, some unavoidable risk factors for atherosclerosis: heredity, aging, being a male. Avoidable risk factors that basically accelerate coronary artery disease: obesity, smoking, lack of exercise, personality, stress, aggression, diet, etc. Okay, that is it for chapter 19. I will see you guys next time. Have a great day.